بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. مساكم الله بالخير for the last session of the day. First of all, my name is Abdurrahman, endocrinologist at King Fahd Medical City in Riyadh. And it gives me the honor and the pleasure today to moderate this session with four eminent colleagues. We will have four lectures, and each one of them will be around 20 minutes, and at the end we will have 10 to 15 minutes for question and answers. It gives me great pleasure to, first of all, let me thank the organizing committee of the first shooting us for this great meeting. And let me please introduce our colleague, Dr. Shaza Muhammad Abu Auf. She's a medical human nutrition consultant and PhD researcher. She's the medical nutrition map center for weight management leader in nutrition map multidisciplinary weight management program team in a private clinic in Jeddah. And she's hydrate and low-fat diet equals low mortality. Dr. Shaza, ahlan wa sahlan, and the floor is yours.
Hello, everyone. Good evening. It's my pleasure to be with you tonight. Thank you for this organized meeting, and thank you for the organization for preparing such a wonderful gathering. I'd like to participate today with my talk, which is mainly it's an intensive evidence about low-carb diet versus low-fat in terms of effective dietary intervention for weight loss, where there is a very big conversions about which one of them it's more effective than others. So I'd like to introduce this for our talk. Should I share the screen now? All right. So the first bit for our talk today, I'd like to consider the effectiveness of different strategies for weight loss in terms of different type of diets, and we would like to examine some of the evidence of how much different type of dietary strategy would be influenced in weight loss. We all know that body mass index is a standard tool we use for identifying the level of obesity and weight. And we know that it's the most common calculated equations we use widely different of thinking or evidence-based. However, body fat evaluation is also it has been found to be essential for evaluation weight loss, weight management programs. That's because lots of studies has found body mass index. It doesn't give a clear indication or a clear identity about each person of their fat percentage or their bone percentage and water mass percentage. So most of the recent evidence has found that the combination between using body mass index as an assessment tools plus fat percentage or fat mass percentage and other body component percentage is really effective for identifying which type of diet will be more effective for certain people, and that's what we're going to all see. We're going to see it in the coming slide. Well, actually, waist circumference is also found is a crucial tools to be evaluated. The reason to be found that lots of people they might be overweight or they might be having high body mass index, okay, without showing a real problem with their body mass index. But when we look at their waist circumferences, we found that they have a massive, huge waist circumferences, which is mainly can lead more to more morbid complications like cardiovascular disease, being diabetic, hypertensive, and so on. So looking at the waist circumferences as a tool also to identify which type of diet approach should be considered is really essential for certain cases. So we could have a person who had a healthy weight, or a normal body mass index, but with a large waist circumferences, which is need to be considered, or it can be identification tools to understand what type of dietary approach should be considered. Um, Indeed, there is also, according to what we said in the previous slide, in terms of like waist circumference, there's mainly two types of body being found: the gynoid and the android. Most of them, they looked at the waist circumferences in terms of their effective for having a metabolic syndrome or not, and mainly those people with the first type of body, they found that they really suffer from they don't suffer from that much of metabolic profile indicator. They mainly have low triglyceride, normal HDL, they have insulin resistance, they have normal glucose tolerance, normal inflammatory markers. However, these people mainly, what they have, they got a high body mass index. And this need to be considered in terms of the measurements and in terms of the evaluation to understand which type it will works better with different groups. In terms of the second type of body with the androids, we normally, these people, they have a risk of metabolic syndrome, which is opposite to the first type of body. And these people also, they really suffer from a long-term health complication more than the first type of bodies. So, skinful thickness, it's been considered one of the very effective tools to understand the type of subcutaneous fats, and to what extent the level of the fats under the skins need to consider how much these people they have the vessels fats, which is we call it the organ fats, the inner fat. So all this type of tool, they have to be taken in consideration with the body mass index, because it's really giving the good indicator to understand which type of diet will be more effective with different type of bodies. So the question here, what type of diet which really help in weight loss the most? We all know that all people and most of the patients, when they come to the clinic, the first thing they ask, I want to lose this weight as much as I can and as fast as we can. So we have to understand, according to different type of evaluation, which we can make it at the beginning, which are all the body assessment tools, in terms of other blood test results, which also can identify of those people who had certain metabolic syndrome complications. We have to identify these type of elements to understand which type of diet can help the patient to lose weight the most. So if we're going to talk about standard, or we can say globally standard eat well plate, we all know, most of the professional people, they know that the eat well plate, it's a standard tool to give people advices about how they can eat and how they can divide their portion size. However, this type of elements, which is the eat well plate, it's not necessary to be fitting all type of bodies and all type of people, because we need to understand a certain type of criteria where where different type of criteria that can fit a different type of diet for helping people to lose weight really in a very effective way. So Eat Well Plate is a standard tool for healthy eating, but not for all type of body assessment and not all type of bodies. So there is always, I use always to love to ask this question is in many conferences and many meetings, which is about different type of nutritional intervention and dietary intervention. That weight loss, it might be simple. Most of the people, they say weight loss is simple. Dietary advices by eating less and move more. Well, actually, this is really a myth, because if everyone can eat less and move more, everyone can lose weight easily. So it's not like by eating less or doing a very restrictive diet and moving more that would help you to lose weight easily. So there is a certain criteria and certain elements we need to consider for effective weight loss. There is a studies being conducted to look at by diet restrictive advice and the calorie prescriptive diets. So they divided two groups of people, and the first group of people they give them a diet restrictive advices that they have to live in a very restrictive diet, not eating this, cutting this. It's we could consider it as a type of a starvation diet, and the calorie prescriptive diet, which normally give to people according to their needs, according to the initial evaluation being done. So when they compared between those two groups for 2 weeks of diet program, and they looked at how much they really effectively lose weight, and they use a 600 calorie defects for most of those two groups. They found that the first people or the first group who had a restrictive diet, 21 of the participants they withdrew from the trial. They didn't continue, and people who received a calorie prescriptive diet, which is really being given and being structured the way they need, 9 of them they withdrew only with p-values, which was really 0.045, which is really highly significant. And when we looked at the research, at the relation between the energy prescriptive diet and the weight loss change between the two groups, the studies has identified that those people who had the calorie prescriptive diet, they lose the most of their diet in compared with the other group. And this can give an indication that usually restrictive diet advices should not be used because they are insufficient in long term and can be harmful. So here we could hit to the main point that restrictive diet is not help. It's not helpful, and if it's gonna be help, it's only for a very short time and not for the long time. So when we look at the diet compositions, we know that recently the propagandas of different diets, we hear lots of names. Okay, the most very common diets were being used in the field, which is the low-fat diet, high calorie versus high carbs diet, or the low carbohydrates diet versus high protein diet, which we call it Atkins. And some people nowadays they call it keto with high protein and high fat. Okay, and the very well known the low and the high glycemic index diets. So if you're going to look at the glycemic index diets, which is one of the top diets, which is being dietary intervention, which is being used globally. And it's been defined by the instrumentals areas under the glucose response curve of 50 grams of carbohydrate from the best of foods. Versusly, there is also something which is we call it the glycemic loaded. The glycemic loaded measurement. The glycemic loaded measurement will look at the load of the carbohydrate in the entire in the entire meal. It's not in the nutrient itself. It's not in the each food type. No, in the entire meal. So there is a little bit differences between both of them. When we look at the example of the high and low glycemic index diets, this being given an indicator of this type, certain type of foods. For example, high glycemic index type of foods, we normally find them in the refined type of carbohydrates like biscuits and cakes and bakeries and all these things. High sugary foods like sweets and dessert and refined sugar. So those are mainly the high glycemic index one, and mainly people they know about it. The low one we can find it in fruits, some type of nuts, some type of vegetable, and sometimes of seeds and legumes. So this is normally the differences when you call high glycemics and low glycemic, because sometimes people they confuse between to these two definitions. Um, in a very nice comparison study where they looked at the high and low glycemic index diets between participants, and they used the criteria of a certain type of application which can help to measure your intakes from different type of we could say starch foods or fruits and vegetables to calculate the intakes of the glycemic index in them. And when they compared between the two groups of those people who really follow, okay, a low calorie diet, or we could say a dietary prescriptive diet according to each person needs, and they compared between low glycemic and high glycemic, but restricted, the average of weight loss, it was, both of them, they lost weight, but the average of the weight loss, there was no big differences in the weight loss according to the glycemic index, which is 1.6 versus 1.5. So everyone lose weight, but with no big differences. No evidence that the long term of any differences being found, and there's no effect of the appetite users in this approach. So their appetite, it doesn't affected by low glycemic or high glycemic index. So we can use low glycemic diet, high glycemic diet with restricted diet. When I say low calorie diet, low prescriptive diet, but both of them of low and high, it won't make any big difference in weight loss. Both of them, they're going to lose weight. So when we look at the low glycemic index versus low glycemic loaded, where we're talking about the glycemic loaded in foods and diet for overweight and obese population, there is a study where they assess the effect of low glycemic index and the loaded diet for weight loss in overweight and obese populations. And what they found, they mainly found that the body mass index has changed, and this been remained for 5 weeks up to the 6-month durations. So the body mass index was discrete for 1.2 in the first group, and the total fat mass being lost, it was 1.1 kg. Body mass index also has changed by 1.3. So there was a significantly greater, significantly greater in participants receiving low glycemic index compared to those who had a low glycemic loaded. So low glycemic index, it's more effective. So before we looked at the low and the high, and we found that the differences was almost similar. But with the low glycemic index and the low glycemic loaded, low glycemic index has been found more effective than looking at the loaded of the carbohydrate. So in conclusion, weight loss, it was more in overweight and obese people advised with low glycemic index and low glycemic diet in compared with those who had low glycemic loaded diet. So similarly, loss of total fat in body mass index also were found to be significantly and greater in low glycemic index or low glycemic diet more than the low glycemic loaded. So this can give an indicator how low carbs diet it can be deferred. So we have to consider the glycemic index with the glycemic loaded. Okay, so weight loss diet with different types of combination. This has also been widely described in different type of meta-analysis and different type of study, where they looked at random trial for 812 participants for 4 different diets. Low fat, which is average protein was taken in this diet was 15 grams, and low fat with high protein, which is the fat percentage was 20 and the protein was 25, high fat, average protein, and high fat, high protein. So they looked at those 4 different type of diets for 2 years duration for individuals with energy defect for 750 calories intakes per day. And what they found between all these four different groups, that all diet, they promoted clinically meaningful weight loss for all the groups. So simply low-fat diet, okay, with average protein, with high protein, with low protein, they all help to lose weight. So that's give a great indication that high-fat diet, when I say high-fat diet, definitely with the monosaturated diet, which is mean with the good diet, with the good fat, good type of fat, definitely not the saturated one. So in conclusion, reduced calorie diet result in clinically meaningful weight loss regardless of the macronutrient compositions. So this is the real fact between those different type of diets being used in weight loss. So what is the value then? So if we have different type of diets, low calorie diets, low carbs diets, high fat diets.
دكتورة شذا.
Yes.
أنا دكتورة شذا.
أيوة.
Time الله يعافيك. Can we finish?
This is the last slide. I finished. خلاص.
Very much.
Yes.
Sorry.
So, yes. So if we're going to look at the effective of this type of intervention, all of them, they give the good indicator for losing weight with a different significant approach. But however, another study has found that lifestyle counseling, it gives the most of the outcome of those different dietary intakes. So when they added the lifestyle counseling to different type of dietary intake, which is remain with low fat and high fat, they found that people who approach who integrate lifestyle counseling, they lost 4.6 standard deviation of their own of their total diet. So very low diet, very low calorie diet. It has a short outcome, but not for the long outcome, and it shouldn't be less than 800 calories per day. Evidence are available for the very low calorie diets, but they show that they have a less effect for the long outcome, the long effects. This is the same thing that looking at how much very low calorie diets is really effective, but it's not for the very long term. So in conclusion, weight loss with a very low calorie diet, it can show a very effective in 3 to 4 months, but not for the long term. Most weight loss should be about 5 kg. That means 5% by 6 months. And should be range for weight loss regulation, and should be very expected for weight loss. Increase in adherence in dietary regimes is very approved, and this is for what we call lifestyle changes. So this is some of the guidelines which is help people, especially nice guidelines. They showed what is the meaningful of the low calorie diet and low fat and the low carb diet, and which one of them are more effective, which can be effective, with which one of the groups. So in summary, one size, it doesn't fit everyone. We need to consider all type of body compositions, body type, satiety and signaling hormones, eating types, eating disorder, stress, sleeping average. Should be considered for more effective diets. And thank you very much.
Thank you very much, Dr. Rashada. I know that you started late because of the technical difficulties, but we are in a learning curve for this new modality of
yeah. Thank you so much. At least that I think we finished almost on time.
Thank you very much.
Thank you very much.
Our second speaker is Dr. Ali Shehri. Dr. Ali Shehri is a consultant in medicine and consultant obesity medicine. He is the chairperson of the obesity department at King Fahd Medical City. Dr. Ali Shehri will, his talk is about medical management of obesity. So we are waiting for hearing from you, Dr. Ali, for the next 20 minutes. Dr. Ali.
Thank you, Mr. Chairman. Thank you very much. And it's my pleasure to be here. Thank you for the organizing committee. And good evening, everybody. I am here to talk about medical management of obesity, and I hope the view is clear now. Okay, so this is the objectives of my talk. We'll review the goal of anti-obesity treatment, and we'll review also the old, current, and future anti-obesity drugs, and we'll look to the impact of anti-obesity pharmacotherapy, and we'll try to give some tips regarding the approach and monitoring patient who's been on anti-obesity treatment. So I'll start my presentation with this slide that summarizes the clinical guidelines for obesity management. And as you know, the management of obesity has three arms: the lifestyle arm, pharmacotherapy arm, and the surgical arm. I think the lifestyle arm was covered well by Dr. Shaza, and I'm here to talk mainly about the pharmacotherapy. One point we need to emphasize about that the lifestyle arm is still the cornerstone of weight loss intervention in all the categories of obesity and overweight. So in general, what's the goal of obesity treatment? First one, to reduce and maintain weight loss, and that will lead to sustainability of the result and to maintain the achievement that's being done by the patient. Number two, improving the health status, and that will be reflected by reducing the risk of obesity-related comorbidities. Number three, minimizing the adverse effects of whatever intervention you choose for your patient, whether it's medical or surgical. And that will lead to enhance the compliance and enhance the long-term compliance of the patient and sustain the outcome. So pharmacotherapy can play a key role in the improving of adherence to lifestyle change plan, and pharmacotherapy could achieve the previous goals through a different effects. Number one, increase the number of people who respond to lifestyle intervention. So when you combine the lifestyle intervention with the pharmacotherapy, there will be a number of people who respond better than the people who will be only on a lifestyle plan. Number two, it will increase the magnitude of that response and the amount of weight loss. Number three, it will increase the duration of that response, and that will lead to more sustainable and more long-term result. The approved pharmacotherapy options work by either one of two mechanisms, either altering food intake or causing malabsorption. So let's go just very quick about the history of medical management of obesity and the anti-obesity drug. Phentermine was the first drug that's approved by the US FDA in 1959 for short-term use. But clinically, the use of such drugs did not take off until the early 90s, which correlate with the dramatic increase in the prevalence of obesity. So they've been using the phentermine in combination. Phentermine is an amphetamine-like substance with combination with fenfluramine, which is serotonin-releasing agent. And it was very common used in the United States. Then in middle of 90s, there was reports about valvular heart disease and other cardiac complications. So it was recalled from the market. So this is the story of the first step regarding the medical management. And after that, some drugs also came to the market and was approved by the FDA, but later it was recalled, and they try to summarize some of those drugs here. So as we mentioned, fenfluramine or dexfenfluramine, both of them is sympathomimetic agent, and both of them withdrawn almost in 1997 due to valvular heart disease and pulmonary hypertension. Rimonabant is another medication which is selective CB receptor blocker. It was approved only in Europe in 2006. And there was a lot of concern regarding the potential psychiatric disorder. So it was recalled again from the market in 2009. Sibutramine, which is one of the most famous medications that been used in the 90s. It was marketed under the name of Fridactyl and Meridia in some countries. It was approved in US in 1997 and in 2001 in Europe. And it's a selective combined serotonin and noradrenaline reuptake inhibitor. It works by suppressing the appetite. Again, it was withdrawal from the market in 2010 due to increased risk of sudden death and heart attack. And lately, this year, in February 2020, there was a recall for lorcaserin, which is a selective serotonin receptor agonist, because of a concern regarding increased risk of solid organ cancer. So this is in summary just a quick background about the history of medical management of obesity. So what about the current situation? So this is the pharmacological option for weight management that's been approved in United States and in Europe for weight management. And you can see there is a variability about the availability of those medication between a region and another. And you can see that the phentermine related substance is not approved in in Europe. So in US, we have the orlistat, phentermine, combination of phentermine and topiramate, combination of naltrexone and bupropion, and lately liraglutide. In our local market, we have only the orlistat and liraglutide. Orlistat is pancreatic lipase inhibitor, and liraglutide is a GLP-1 agonist. Those medication usually is used in combination with lifestyle plan for people who has obesity with BMI more than 30, or people who has overweight BMI of 27 or more with obesity-related comorbidities. So I'm gonna take a few minutes to talk about the two medications that's approved here in our area, which is the orlistat. It's a pancreatic lipase inhibitor. It shows benefits regarding diabetes, cardiovascular risk, and lipid, and it has an adverse effect of cramps, flatulence, fecal incontinence, and malabsorption of fat-soluble vitamins. And there is some rare side effects like liver injury or calcium oxalate kidney stone. It's contraindicated during the pregnancy, and the optimum dose is 120 milligram 3 times daily. You can cut the dose by 50% if the patient could not tolerate this dose. So here you can look about the effects of the orlistat and compare with the placebo in people who has diabetes or people who doesn't have diabetes. And you can see that those people who's been on orlistat, they have achieved better glycemic control, and they achieved better weight loss, almost 5% total body weight loss at 1-year point. And that's hitting the benchmark for the FDA for approving weight management drugs. So again, in the same study, comparing the people who lost more than 5% or people who lost more than 10% total body weight loss with orlistat, and you can see that there is a significant difference between people who use the orlistat or people who were only on lifestyle plan, in the placebo arm. So the second drug is liraglutide, which is a chemically modified version of human GLP-1. It's a gastrointestinal peptide that stimulates glucose-dependent insulin secretion and inhibits the glucagon release and gastric empty process. It has a gastrointestinal side effects, mainly nausea, vomiting, diarrhea, and constipation. And in patients with type 2 diabetes, you may have risk of hypoglycemia. There was a rare report about pancreatitis and gallbladder disease, mainly acalculous cholecystitis. It's contraindicated in pregnancy and in patients with personal or family history of medullary thyroid cancer or multiple endocrine neoplasia 2A or 2B. It has an escalating dose started by 0.6 milligrams subcutaneous, and then you increase it gradually on weekly interval by 0.6 milligram till the full dose at 3 milligram daily, and the re-evaluation almost after 16 weeks of the full dose. So here is the scale trials, which is very famous trials, look to the effect of liraglutide in patients with pre-diabetes, diabetes, sleep apnea, or even on weight maintenance. And there was significant difference in people who's been on liraglutide compared to people on placebo in all the arm of scale trials. And you can see almost more than 50% of people who enrolled in this study, they lost more than 5% on liraglutide, and more than a quarter of those patient, they lost more than 10%. In scale maintenance, they looked about the effect of combining the lifestyle with pharmacotherapy after enrolling patients on a lifestyle program for 3 months, and they lost around 6% total body weight loss. They add for them pharmacotherapy, and they found that people who use the pharmacotherapy in combination with the lifestyle plan, they were able to lose another 6% of total body weight loss, and they were able to maintain their weight for long term. So this is the other drugs which is available in other markets other than our market, but it's still approved to be used for obesity. And the first one is phentermine topramate. It's marketed under name of Casemia in US, and I think in UK it's under name of Mesemba. It's a very good drug. It's a sympathomimetic agent, combination of sympathomimetic agent, the phentermine, with anti-epilepsy drug, which is the topramate. It can give up to 10% total body weight loss, and again, it has a gradual dose that could help the patient to accept the side effect or tolerate the side effect. The most common side effect of this combination is dry mouth, constipation, depression, elevated heart rate, and there is a risk of abuse potentiality, especially with the phentermine. Also, risk of teratogenicity with topramate. So you should avoid this drug with women who's at childbearing age. It's contraindicated during pregnancy, hyperthyroidism, and with patient who has psychiatric disorder. The second combination is Contrave, which is a combination of bupropion and naltrexone. And this medication, it's combination of an antidepressant or anti-smoking cessation drug, which is the bupropion, with an anti-opioid drug, which is the naltrexone. And this drug is being used mainly for people who has some craving for some types of foods. For example, sweets or salty food. It's work really good, and it could work better if you add it as a second line of therapy. I believe some of the Gulf countries started to have this medication, mainly UAE. I think they start to have it. I have some patients who start to bring this medication from UAE. So again, it has an escalating dose to avoid the side effect. Side effect is nausea, constipation, headache, and there is a risk of transient increase of blood pressure. So you should make sure that the patient has well-controlled blood pressure before starting such medication. The risk of seizure, and it's contraindicated also in eating disorder or patient with uncontrolled depression. The last one is phentermine, which is approved in US, as we mentioned. It was the first medication that approved for short term, but some physicians, especially in US, they use it for long term. There is an scare about the risk of addiction and abuse potentiality, but it's appeared that if you use it under good supervision and choose the right patient for this medication, it could give a good result, and the risk of addiction is very minimal here. It could give up to 7% total weight loss. And it's, again, has a gradual dose, and it has almost the same side effect of the first medication, the Casemia. Some of these medication or some of these part of them, like bupropion or topramate, it's used in some clinics as an off-label medication to treat the obesity. The effect is variable, but I don't recommend anybody to use the drug as off-label medication unless to be used by an expert person who know how to handle those medications. And unfortunately, those 3 medications are not available here, and it's not Saudi FDA approved. I think I heard that phentermine is available in some private hospital here. I don't know how they order it, but I heard that it's available in some private hospitals. So here we can look, we summarize just the efficacy of those medication at 1 year point. We can see that the combination of phentermine and topromate almost hitting 10% total body weight loss. The second most effective drug is the liraglutide, about 7 to 8% total body weight loss. Orlistat almost touching the 5% total body weight loss. But due to the intolerable side effects of the orlistat, and a lot of patients, they will not be able to tolerate the side effect of this medication. It's not widely used in our practice, but there's some patients who prefer to use this medication, especially people who has a desire to eat a lot of fatty food. So in the scope for care of obesity, this is where the medical management part localized. It's localized somewhere between the lifestyle and surgical part. And this is the area where the pharmacotherapy could work better. When you combine the pharmacotherapy with the lifestyle modification, it could give the results or could push the results of total body weight loss to an area close to the bariatric surgery measures. So this is a kind of integration between the three arms of obesity management and clarifying the role of the pharmacotherapy in this integration. So the pharmacotherapy impact on body weight, it's compared with diets and exercise alone. Pharmacotherapy increased the proportion of people achieving clinically significant weight loss by about 50%, increased the amount of weight loss achieved by about 3 to 7%, and increase the duration of the weight loss maintenance, and that's lead to continuity and sustainability of the results and helping the patient to keep the weight that they lost off. So again, if we look to the behavior therapy alone or the intensive behavior therapy alone, it could give something like around 5% total body weight loss. Pharmacotherapy again alone could give maximum up to 10% total body weight loss. But if we combine them together, we could push the result furthermore. So this is again emphasizing the point of integration between the different arms of obesity management. So greater weight loss will further improve the obesity-related comorbidities. In some situation, it can lead to delay of progression of these complication or delay of the diagnosis or even remission in some situation. So in diabetes prevention, you need something around 10% to increase the chance to prevent the diabetes. Diabetes remission, 15% could start to increase the chance to have a diabetes remission, and a hypertension 5 to 15% total body weight loss will improve the blood pressure reading significantly, and the same for dyslipidemia. 10% total body weight loss for fatty liver and sleep apnea will impact very significant on the symptoms of the patient and on the condition of the patient who has obesity. And the same scenario happened with the other comorbidities. This is just an example of a huge range of comorbidities that is related to obesity. So here is just some tips and some advices before you start any patient on pharmacotherapy or you choose the pharmacotherapy for any patient. The first point is counseling the patient about healthy lifestyle, physical activity, whether this patient will use pharmacotherapy or not. It's very important to counsel this patient and to refer him to the nutrition to get the proper advice from the specialized people. And I prefer that the physician leave this job for the nutrition if it's available in the clinic. The second thing is approaching to the underlying comorbidities. So during the initial evaluation of any patient who has obesity or overweight, it's very important to address the weight-related comorbidity conditions such as diabetes, dyslipidemia, hypertension, and take all these complications in your consideration when you choose a drug to start on this medication. Number three, number three, yes.
Can we just finish in 1 to 2 minutes, please, because we have to.
Sure. So you should make sure that this patient met the criteria for medical therapy, and during choosing the agents, very important to consider the comorbidities, contraindication, insurance coverage, and cost. And how long should pharmacotherapy be used? Obesity is a chronic relapsing disease, and if the treatment is stopped, the possibility of weight regain is high, so patients should continue in the medication almost for life. So very quick look about what's coming in the horizon regarding the anti-obesity drug. There is many drugs under trials now, and I try to just give some example in this table about some drugs that's been investigated to be approved for obesity. And if we choose one of them, which is the most close one to be approved, is semaglutide. And I'm sure most of you has started to use this medication, especially with the diabetes. Diabetic form for this medication is approved already and it's available. So in the phase 2 trial for this medication, it hit almost 16% total body weight loss. That was almost in 2017. Preliminary reports came this month from phase 3 trial, shows that semaglutide at 2.4 could achieve weight loss of 17.6% compared to 5% with placebo. And 90% of those people who receive semaglutide, they lost more than 5%. So this is very good and very promising results. We are almost touching the results of the bariatric surgery. So this is, I think, very promising field, and I hope this medication will get the approval for from the FDA for obesity. So before I conclude my presentation, just again emphasizing about the integration between the different arms of obesity management, behavior therapy, pharmacotherapy, and surgery. It's all connected together and all related to each other in a way or another. So in a conclusion, pharmacotherapy combined with lifestyle therapy increase the proportion of people who respond and increase the magnitude of response and duration of response. It increased the magnitude of weight loss that help to improve the obesity-related comorbidities. Obesity is a chronic disease, need long-term follow-up and management. Evidence of integration and combination between different approach for obesity, between the different arm of obesity management is very important. So thank you very much. This is the end of my presentation, and I will handle the mic again to the chairman.
Shukran, Ali. Thank you very much. And I'm sorry for the being pushy because of the time. You know, we have like 20 minutes for each presentation. Our third speaker is a rising star in the obesity medicine. Dr. Hussein Al-Badawi is an American board of obesity medicine and consultant in endocrinology and diabetes metabolism. He is clinical assistant professor of medicine at Wayne State University. He is a chairman of the metabolic unit at My Clinic Center in Jeddah. His talk today is in people with the obesity, what keeps weight loss sustained. Dr. Hussein, please, the floor is yours in 20 minutes.
Thank you very much, Mr. Chairman, Dr. Abdurrahman, and good evening, ladies and gentlemen. Thank you for tuning in today, and hopefully I will keep you engaged in this very hot topic of what to do once we lose weight, and how can we maintain that weight loss, because it's a struggle, not just for our patients, but us as providers in this field. I also would like to take the chance to thank the organizers for the invitation and appreciate bringing them with all of us together in this blessed night. So the agenda will go through a brief introduction about obesity. We'll talk about appetite regulation, and then what happens after weight loss and what are the barriers and some of the solutions that we can overcome. I am cognizant of the time, and I will try to just go through whatever is simple quickly to maintain our time frame. As we all know, obesity is one of the top 5 health concerns worldwide. It is defined as excess adiposity, which leads to comorbidities, or in an anthropometric calculation, measurement of your BMI, of your weight, in kilograms divided by your height square. If you hit 30, you are at obesity. And then you have classes of obesity that range from 1, 2, and 3. There is also a staging system. But in the end, obesity, we should all agree tonight that it is a disease. And if you claim that a certain health state is a disease, then you imply that one, it will cause harm. So there are complications to it. And that there is a pathophysiological mechanism for it to occur. And that if it is a chronic disease, then it is usually there for a very long time, and usually chronic diseases are progressive. And that all was well established in obesity. So it is chronic. These are definitions by different organizations and societies. It is a relapsing disease. It is progressive. It leads to a disease state. It is actually a disease state. It is quite prevalent worldwide, not just because of the way and the culture that different societies engage in, but also this issue of losing weight and not being able to maintain it has also added to the burden of and the prevalence of this obesity. If you look at our region here in the Gulf states, we are competing with the rest of the world in being amongst the highest in prevalence, reaching almost more than a third of the population at the obese state. As we said, complications will arise if we stay in this state, whether they are metabolic complications such as type 2 diabetes, hypertension, dyslipidemia, or fatty liver disease. We also have mechanical complications because of the fat burden or the weight that is imposed on joints or on backs, which leads to chronic back pain and osteoarthritis at early age. And we also have the mental complications, which have been seen in many studies, such as anxiety and depression. Now, as we said, the corner pathophysiological defect starts from adiposopathy, which means bad fat getting into more inflammation that leads to pathology within the fat tissue. So excess accumulation of adipose tissue will aggregate and lead to accumulation of pro-inflammatory cells that lead to increasing adipocytokines, which lead to an increased inflammasome or an inflammatory burden throughout the body. This leads to different diseases such as insulin resistance, the lipotoxicity that will lead to NAFLD or steatohepatitis, which leads to cirrhosis, and then increasing sympathetic overdrive that leads to increasing hypertension and cardiovascular disease. That's on the metabolic side. As we said, the excess fat and weight that is imposed on different structures can lead to osteoarthritis, can lead to reflux disease because of the increased abdominal pressure, and many other disease states. Now, let's talk about appetite regulation. And if we go into a certain area in the brain called the hypothalamus, and I take you to the area called the arcuate nucleus here, where I can tell you there are two major nuclei known as the POMC-CART nuclei and the NPY-AGRP. So POMC-CART, poropiommelanocortin, cocaine, amphetamine, reverse transcript. If I stimulate these neurons, they will stimulate second-order neurons that lead to satiety and the sensation of feeling full and decreasing appetite, which leads to reducing the food-seeking behaviors. If I come to the NPY-AGRP nuclei and I stimulate it using ghrelin, which is the hunger hormone, this will lead to the sensation of hunger, which leads to increasing appetite, which leads to food-seeking behavior and increased energy intake. Now, this all acts in a crosstalk fashion with a different nucleus in the hindbrain, which also controls through parasympathetic nervation to the stomach and the gastrointestinal tract. That will lead to the sensation of fullness and gastric emptying as well. So if I take you through the reasons for eating, in general, we have a homeostatic mechanism, which is what I just described, the balance and the equilibrium between the eating because of hunger, for food-seeking behavior because of energy, and that is controlled through the hunger hormone signal coming from the stomach, which is the ghrelin, and the counteracting regulatory hormones such as gluconeolipeptide 1 or GLP-1, PYY, which increase satiety. Now, sometimes as our culture in certain events may eat for the sake of pleasure or for the sake of being pressured by social stresses. You go to your cousin, to your mother, to your grandmother, to your mother-in-law, and you are asked to eat more because even though you are full. This is where the hedonic pathway will be activated. So we sometimes, as I said, in the state of feeling full, may reach for that cookie that has a very nice topping, or a cake that has a glare to it, or you remember the texture and the pleasure that you will receive once you eat such a thing. And that is known as the hedonic pathway, which is eating for pleasure, which is controlled by dopamine as a neurotransmitter, and in other pathways through the opioid and cannabinoid receptors, which all crosstalk in the end through the ultimate brain processing centers, which are the higher centers, which are empowered by your behavior. So if you get these signals of food and attraction to it, what will hold you from reaching out for it is your behavior. And this is where many patients may struggle when it comes to weight maintenance. So behavioral intervention is where we empower the higher centers in controlling food-seeking behaviors. Now, we all know that weight loss, as Dr. Ali have showed us, that can lead to reducing the chronic diseases that come as complications of obesity. Now, meaningful weight loss is between 5 to 10%, as was already presented by our speakers throughout this evening. And there are many guidelines, as we have seen, onto how to achieve that weight loss, starting with diet intervention, exercise, which is the baseline cornerstone for any obesity therapy program. And then we can add pharmacotherapy depending on the state of comorbidities available, and surgery is there. And as Dr. Ali has shown us, where pharmacotherapy can play a role in reaching that weight loss, we also have surgical options which will lead us to that weight loss. Now, how can we maintain the weight that was lost? Now, this is a study that looked into all the dietary studies and nutritional interventions that achieved meaningful weight loss. And you can see the columns here represent how many kilograms were lost at every single intervention. So between 5 up to 30 or 25 kilograms were lost. But when they went back to seek what happened to the subjects 4 to 7 years later, in light blue are the columns of the patients who and their state of weight loss. So the majority have regained the weight that was lost. And this is just to show you that obesity is a chronic disease, and it's not just a matter of losing weight, because dietary interventions and exercise have been proven to lose weight or make weight loss successful. It's a matter of maintaining that weight loss. So the weight rebound phenomena is a real phenomena that is seen even in murine studies and animal studies. But this is an intervention that showed what happens after a very low caloric diet. So talking about less than 1,000 calories per day within a certain intervention. If you monitor these patients over the next 2 to 3 years, so after achieving weight loss down here by almost 10 to 15 kilograms, with time, patients tend to regain weight. And this was also seen in patients who lost weight through diet and behavioral therapy. as well as a very low caloric diet, less than 800 kilograms. So you achieve more weight loss, but then you still have this rebound weight gain, I'm sorry. Now, again, these are different studies throughout the years that all showed you that after a certain intervention, there is usually some weight regain. Our challenge is maintaining that weight. So let's take a look at why is it that we always regain that weight. And part of the issue is because the balance between the energy intake and expenditure is disrupted by something in the middle, which is our body is reset after weight loss. So if I lose 10 kilograms, then my body will tend to act in a way that secretes hormones that preserve more energy. So if I lose weight, my gut hormone will start to increase ghrelin hormone at baseline. It will also reduce the satiety hormones. Not only that, but also the food-seeking behaviors and desire and appetite will increase in patients who lose weight. Now, there is something known as metabolic adaptation. If I tell you that obesity protects obesity, meaning that an obese individual or a patient with obesity, once they come down to a overweight state or a normal body weight, this new state has different characteristics from what it was in the past. There is something known as an energy gap, and I'll get to that in a few minutes. But basically, when you lose weight, your hunger goes up because of the hunger hormones, and the hunger signals go up. Your satiety hormones go down, so you do not feel full as you had in the past when you reduced the same amount of food. The energy expenditure also goes down. So imagine that you have a furnace or an oven that's at 250 degrees that's burning at a certain rate, your basal metabolic rate. Once you lose weight, your body's going to actually drop down that temperature. So you actually burn less even though you lost weight. Now, how do you overcome that? This is where the interventions will require you to reduce more of your intake, increase more of your expenditure. Now, if we take a look at surveys worldwide about patients who have been able to lose weight, this was the Action.io study where they surveyed 14,000 patients, and you'll see 38% were able to lose 5% body weight. Now, come 1 year later, only 11% were able to maintain that weight. That's a very low degree. And the same when they looked at the questionnaire posed to physicians, they told them that, yes, 35% of my patients made serious weight loss efforts, but only 30% were able to maintain that weight loss. And as I told you earlier, the hunger signals go up. So this was a study of 50 individuals after they put them on a very low caloric diet for 10 weeks. You'll see that they all achieved weight loss. But then with time, the weight went up, and you look at the hunger signals by surveying them went up even more. Now, the problem is that even though they regained the weight, when they came to eat again, the satiety signals also went down, and therefore they did not feel completely full at the end. So if I show you this graph where my initial weight is here, and I force feed you to gain weight. And they actually did this on medical student subjects. What they found was with time, your body will try to actually burn off that extra weight and bring you back to your initial weight. And this is the concept of having sort of like a lipostat, or your body is more comfortable with a certain degree of weight and fat. And if I make you lose weight by 10% or 20%, your body will actually enter a phase of energy saving behavior. So it will reduce the temperature, like I told you, or in the state of force feeding to make you gain weight, it will actually increase the temperature at baseline to have you burn off that extra caloric intake. This was a study of looking at patients at baseline, 30 weeks after diet, where they were able to lose almost up to even 30 kilograms. But then 6 years later, here's the problem. The majority regained the weight, but look at this. This is very scary. The metabolic adaptation led to a decrease of almost 500 kilocalories per day of lower basal metabolic rate. So this tells you that our body works against us. And this was an intervention where it showed you that we can probably overcome that by using an anti-obesity medication. So these were patients who lost weight, and with time, either were left to go back to their normal state or placed on a medication. So using pharmacotherapy for weight maintenance is an option. I want to show you something called the National Weight Control Registry. These are individuals who were able to successfully lose weight, and this is my last slide, over a period of almost several years. And so they lost weight and maintained that weight. And they asked them, what is it that you do? These were a big registry, and all of them, or the majority of them, had these characteristics in part of their lifestyle. And this is what I tell my patients to do after they have lost weight. One, eating breakfast. So 78% of these patients were eating breakfast on a daily basis. So it is a good behavior. Two, they weigh themselves at least once a week. So that is part of the feedback mechanism to maintain weight. Three, they all watched TV by less than 10 hours a week. They all exercise almost an hour a day. So in the weight maintenance period, your energy expenditure should go up. We know that patients can regain weight after surgery, and this is why in the Saudi guidelines of bariatric surgery, that you can use liraglutide, as Dr. Ali showed us, even post-therapy. He showed us also the scale maintenance program, and I'll just say that, remember, liraglutide is not just approved for weight loss, but rather also for weight maintenance. So it can help patients achieve the weight loss, maintain that amount. In summary of what I just presented, obesity is prevalent globally because partly because you need to maintain the weight that was lost. Weight loss maintenance requires implementing the basics, which is a lower energy intake and increasing the energy expenditure. Pharmacotherapy is a valid option. Here in Saudi Arabia, the most effective is liraglutide 3.0 milligrams daily as an adjunct to diet and exercise. I thank you for your attention and looking forward to the discussion.
Shukran, ya Hussein. Shukran. Thank you very much. We are behind time, like 10 minutes, so please excuse me for being pushy. Our last lecture will be with Dr. Mahfoud. Dr. Mahfoud, I don't think, Dr. Abdul Rauf, I don't think you need anybody to introduce you. Dr. Mahfoud is a senior endocrinologist. Almost all of us had seen his presentations and his lectures, and actually we learn a lot from Dr. Mahfoud. We will shift gear now from obesity to diabetes, and Dr. Mahfoud is going to talk to us regarding the standards of care evolution in cardiovascular risk management in type 2 diabetes. Dr. Mahfoud, the floor is yours. Please, thank you.
Can you hear me now?
Yes, yes, yes.
Okay, great. Now, let me see. Okay, great. Thank you very much, Abdurrahman, for this lovely introduction, and thank you for this energetic organizers who have organized this lovely meeting. It's past midnight for me, so if I fall asleep, please, you know who to blame. So next time, organizer, please put me for 6 o'clock. I'll probably be more awake and energetic. So as you are well aware, diabetes and cardiovascular disease is very well so to speak, are friends. In fact, many people would say that diabetes is a cardiovascular disease, and it has been on the burner for the last 40 years or so. However, it really has come to more attention only in the last 12 years with the result of many of those cardiovascular outcome studies. So as you are aware, diabetes is associated with microvascular complications in the form of retinopathy, neuropathy, and nephropathy. And these are responsible mainly for the morbidity in diabetes, but it's also associated with macrovascular diseases such as MI, stroke, and peripheral vascular disease. And this is associated mainly with mortality. So it is estimated that about 50% of death in diabetic patients results from cardiovascular disease. And one important information that has come again from these cardiovascular outcome studies is the importance of heart failure in those patients. So heart failure is common comorbidity in patients with type 2 diabetes, and it's estimated that something like 15% of type 2 diabetic have heart failure. And this is about 2.5 times more common in type 2 diabetes compared with those without type 2 diabetes. And in fact, it is 3 times higher in patients with chronic kidney disease for reasons that you are very aware of. As I mentioned earlier, the issue of whether glycemic control or hypoglycemic agents affect the cardiovascular outcome has been with us since the 1970s, since the study that's called University Group Diabetes Study came into existence, which was sort of a controversial study. In fact, the first hint that maybe some of those medications may impact cardiovascular outcome come from the UKPDS. That is a United Kingdom study, and that shows in a subgroup of patients who are actually obese, who are on metformin, there was a hint that there was a decrease in the risk of myocardial infarction. However, that sub-studies is really subgroups are small numbers, and the actual p-value just borderline. The sulfonylureas have been controversial ever since they came into existence. And in fact, in the same study, UKPDS, it was shown that reducing glucose levels is associated with decrease in microvascular disease. However, they were found to be actually safe, so to speak. It is only that Carolina study that was published, and it is the only study that actually compared the newer insulin secretagogue, that is DPP-4 inhibitor, linagliptin, versus glimepiride, that actually shows that both were actually safe in terms of cardiovascular safety. The thiazidines have a very rocky start and have a controversial, actually, period where it was a sort of a mixed picture, with rosiglitazone having been accused of increasing risk of MI, while pioglitazone have shown some studies to reduce 3P MACE compared to other drugs. So here comes the cardiovascular outcome studies, and you probably are aware how they come around. They come around because the FDA issued the guidance to all companies that any new diabetic drug should undergo cardiovascular outcome study to show that it is safe. And this comes from the fact that rosiglitazone in at least the phase 3 study was shown to increase myocardial infarction. And as you can see in this slide, this is a summary of the SGLT2 inhibitors and GLP-1 agonists who were shown to have some positive results. So if you look at 3P MACE here, and 3P MACE basically stands for non-fatal MI, non-fatal stroke, and mortality. And as you can see that empagliflozin shows a 14% reduction, Cana 14% reduction, but not dapagliflozin. In the GLP-1 agonist, there was also reduction by liraglutide, by semaglutide, and by albiglutide. Albiglutide is no longer in the market because of poor efficacy in terms of glucose control and weight reduction. However, as you can see, it had a very good reduction in MACE. When it comes to cardiovascular death alone, only empagliflozin and LEADER shows reduction in cardiovascular death. However, with heart failure, all of the SGLT2 inhibitors shows reduction in the incidence of heart failure. In terms of non-fatal stroke, the sustained and the albiglutide shows there was a reduction in non-fatal stroke and non-fatal MI. This is hot off the press, so to speak, and was actually presented last week in the virtual American Diabetes Association meeting. And this is the last SGLT2 inhibitors to be presented. This is ertugriflozin, and it was disappointing results in that it did not show any differences in MACE between a placebo. Again, cardiovascular death or heart failure, there was a trend, but it was not significant. And if you look at cardiovascular death alone, again, not significant. However, in the heart failure, there was difference. And all of them, you can see the separation of the curve at the very beginning. And just remember this here, you can see that all of those parameters that we look at in the form of MACE, cardiovascular death, non-fatal MI or stroke are basically in neutral, and basically there is no difference. I'm just bringing this study there because this is not a cardiovascular outcome study, but a DAPA in heart failure study, in reduced ejection fraction heart failure study, and it was positive. And we're also looking forward to other studies, of course, in empagliflozin and the others. So let's look at the EMPERIC outcome, which is the first cardiovascular outcome study to show positivity, that is superiority compared to the placebo. And this study actually conducted on 42 countries with 7,000 patients, in patients who have established cardiovascular disease, as shown here. It had 3 arms, and I'm going just to present the placebo and the combined, as the two are the same, lasts for 3.1 years. And again, like on all cardiovascular outcome studies, it looks at the primary outcome as a 3P MACE, and there are some specified component and secondary outcome as well. And as you can see here, somehow I have lost a slide. I hope it is in the other. In terms of cardiovascular death, there's a very significant 38% reduction in empagliflozin arm compared to placebo. And as you can see, the curve separates very early in the course of treatment. Similarly, in terms of hospitalization for heart failure, there is a reduction of 35%, and again, a very early separation in the curve. And if this reduction in cardiovascular death and heart failure was consistent in patients, whether they have established heart failure at baseline, and remember, in this study, there is only 10% of the population have heart failure, the 90% did not. And as you can see, there is a definite significant reduction in heart failure in those patients who did not. And there's a trend because there are a smaller number in those patients who have heart failure, and therefore the line crosses the midline. Again, this is the cardiovascular death. This is the heart failure. And again, you can see both who did not have heart failure at baseline versus those who have it. So if you just summarize this study, there is a reduction of 14% to 3P MACE, 38% reduction in cardiovascular death, and 35% in the risk of heart failure. And all-cause mortality was reduced by 32%, mostly accounted by cardiovascular death. So if I just put all of the SGLT2 inhibitors in one slide, you can see that when you look at the MACE, there's significant reduction in EMPERIC. Similarly, in the CANA program, especially those with established atherosclerotic vascular disease, but not in the dapagliflozin. And if you look at cardiovascular death, again, summarizing them, we see only in EMPERIC that there is a reduction, significant reduction in cardiovascular death. If you look at all-cause mortality, it's only in EMPERIC. And if you look at all of those and compare a real life or a real life results, and this is here in the EMPRISE study, where basically they looked at patients in a clinical, basically in the clinic, and you can see the result more or less mirrors that of the randomized trial. So just to summarize this, that if you look at kidney outcomes, So we looked at cardiovascular outcomes. So if you look at the kidney outcomes, the benefit in SGLT2 inhibitors was very marked and consistent, not so as in GLP-1 agonists. So here is the empagliflozin in parag kidney, and as you can see, it reduced the relative risk of incidence or worsening nephropathy by about 39%. And again, a very early separation in the care that continues and actually separates even further with time. So if you put this into number needed to treat, you can see that empagliflozin, you need about 39 patients to prevent one event for 3 years. Compare that with LIRA, about 98%. And if you look backwards about 20 years or more, simvastatin treatment for 5.4 years, you need about 30 patients to prevent one event. Ramipril in the background of statin, of course, you need about 56 patients to prevent one event. If you basically extrapolate the line for EMPA for 5 years, you'll get this result where you need really 25 patients to prevent one event. And this is impressive. This is in the background of ACE inhibitor or ARB and statin. So that is an important parameter, an important news for patients with diabetes and cardiovascular disease. The result of these obviously had a major impact in our guidelines. And if you remember before the results of those, you actually have a free choice between all of the hypoglycemic agents. The only criteria that you would have is whether you want to save money, reduce hypoglycemia, or reduce weight. However, with those studies in the background, the paradigm has changed, and there's a paradigm shift where there is it's important to look at your patients not in terms of glycemic control, but in a more holistic way, and look at them in the form of cardiovascular status. So if you have patients who have established cardiovascular disease, then it is extremely important that GLP-1 receptor agonists, preferably, or if not tolerated, SGLT2 inhibitor with a proven cardiovascular benefit should be chosen. If on the other hand, you have a patient who have heart failure or a chronic kidney disease, then SGLT2 inhibitor should be preferred with evidence of reducing heart failure and CKD progression. If none of those are tolerated or contraindicated, then GLP-1 receptor agonists with a proven cardiovascular benefits should be chosen. And this is basically a summary of what we have talked about. And for the sake of time, I'm going to skip through this and go to the other one. Here is the European Society of Cardiology guidelines last year that recommend the use of glucose therapy with a proven cardiovascular benefit in patients with atherosclerotic vascular disease or very high or high cardiovascular risk. And this recommendation goes further than the previous one in that it tells you basically if you have a patient with atherosclerotic cardiovascular disease or very high risk of cardiovascular risk, and they don't have diabetes, but they have been just diagnosed with diabetes, then you should go first to SGLT2 inhibitor or GLP-1 and then to metformin. If you have an established patient with type 2 diabetes and atherosclerotic vascular disease, then again use more or less the same criteria. So this recommendation here puts those medications in front of metformin in patients who are type 2 naive, who have been just been diagnosed. Just to show you the level of evidence from this guidelines, and as you can see, the green is level 1 and the orange is level 2B. And as you can see here, for example, empagliflozin recommended to reduce cardiovascular disease, to reduce risk of death. And in terms of reduction of heart failure risk, all of them are basically recommended to lower the risk of heart failure hospitalization. And as you can see, management of chronic kidney disease, SGLT2 inhibitors are recommended to reduce progression of diabetic kidney disease. So we really have gone through a metamorphosis and a really paradigm shift in treatment of type 2 diabetes. And for all of us, we should look at those patients not in terms and in a glucose-centric way, but rather in a holistic way, looking at their cardiovascular risk and kidney disease risk as well. And I believe this is my last slide, and would like to thank you for your attention. And I think I have done this with 1 minute to spare. Thank you very much.
Excellent. Thank you very much, Mahfoud. It's brilliant as usual. For the organizer, do you have some time for the questions? I have one question from the audience for Dr. Rashada. Is keto diet regimen is best for obese type 2 diabetic patients for weight loss?
Yeah, this is one of the main area where everyone talking about the ketogenic diet. Ketogenic diet is one of the very famous diet can be used widely. Actually, yes, because type 2 diabetes mostly keto diet is very beneficial for people with insulin resistance. And mainly people with type 2 diabetes, they have insulin resistance. So what is being found, and most of the evidence found that when we use the fat resources in our body, it's really helped with people who had problem with insulin and those who had insulin resistance, which is not helping them to lose weight. So the ketogenic diet is very useful for type 2 diabetes, but with certain condition. For instance, people, they misunderstand the meaning of the ketogenic diet. Ketogenic diet is not the consuming of every type of fat you want. So we need to put in two brackets that we need to use monosaturated fat, not the saturated fat.
Shukran. Thank you very much, Dr. Rashada. Dr. Ali, you have probably a similar question. Is it possible for type 2 diabetic patient to start in keto diet? Dr. Ali,
Yes.
So it's the same question almost.
Yeah, but for type 1, not type 2.
Type 1 or type 2?
Type 1.
Type 1. So
ask Sada later to comment. Yes, Ali.
Yeah. I think Dr. Shoda is the best guy to answer about this, but I'll share my opinion in this point. I think regarding the diet, there is nothing yes or no, and every patient, the diet is an individualized. So for every patient, you should make for every patient his or her own diet. Keto diet, it has a risk and it has a benefit. All the studies about short-term effect. There is no long-term effects. Well published study about long-term effects of ketogenic diet. Risk in type 1 diabetes. Ketogenic diet could proceed to further hypoglycemia. Patient should monitor their ketones frequently because those patients at risk of developing diabetic ketoacidosis, although there is a difference between ketosis that's coming from the nutrition and ketoacidosis and the blood sugar and the type 1, which is associated with high blood sugar. So I think if any patient, whether type 1 or type 2 or whoever, want to do ketogenic diet, it should be under very close monitor and under medical supervision by a registered dietitian and by a physician supervision.
Yeah, I'll go to Shada, but there is one question for you also. Would you advise using metformin for weight loss?
Yeah, so metformin is one of the off-label medication that we use for weight loss. Metformin is not anti-obesity medication. It's not FDA approved for weight loss, but it could be used. Personally, I use it, especially for people who has like overweight or class 1 obesity, and they have some signs of insulin resistance or pre-diabetes, or people who doesn't prefer the injections. Yes, I use it. It gives some effect in some people, and sometimes even the placebo effect to give the patient the accountability and the push to lose weight in association with lifestyle, it could be used. So I would not mind to use this.
Thank you very much, Ali. Oh, Dr. Rashada, would you comment on the ketogenic diet on type 1 diabetes, please?
I just have a very clear statement here. Okay, ketogenic diet it considered one of the best diet really for people who are diabetic 1 or diabetic 2. The reason out of this that ketogenic diet it's really lead to balance the insulin in the body, and those people who are really suffering from problem with insulin, ketogenic diet is the top to be used for them. That is the main reason why ketogenic diet is good for diabetic patients.
Okay. Dr. Mahfouz, can we use the SGLT2 inhibitors with diuretics?
Oh yeah, absolutely, absolutely. So if you look at the studies, actually, like for the IMPEREC, for example, something like at the end of the study, 60% of the population in that study used diuretics. In fact, initially I think it was 40%, and then they had to add 20%. And people who are afraid that they'll have dehydration or whatever, it didn't occur in that study. And that's 7,000 patients, half of them received SGLT2 and diuretics. So absolutely. In fact, now we know that you can use it, for people with heart failure in addition to the others. Just like using, for example, spironolactone, which is diuretics, with the other diuretics for heart failure. Yeah, absolutely. There is no contraindication whatsoever.
Yeah, there is a question. I think it is a clear answer, but they ask about, do SGLT2 inhibitors reduce mortality and morbidity in heart failure? I think you just made it very clearly for us. So
yes, absolutely. So if the cardiovascular outcome study, the IMPEREG, it does reduce cardiovascular deaths. In the others, it did not show it. But in the DAPA heart failure with reduced ejection fraction, it does show reduction in heart failure cardiovascular death.
And what is the underlying mechanism of high amputation rate with SGLT2?
The underlying mechanism of, I'm sorry, of what?
Amputation.
Oh, okay. So this is, again, this is a post hoc, what do you call it, thing, but it has not really materialized. And we don't know if that's true. I think it is not true, to be honest with you. It occurred basically in patients who already had severe peripheral vascular disease, who already probably had amputation. In many of the other studies, it didn't come up. It only came up in one study, which is the canagliflozin. And in fact, in the other studies, none of the other studies shows an increase in amputation. So this is probably an outlier, I would say, rather than true. But you really have to be careful in those patients who already have severe peripheral vascular disease and amputation anyway. I mean, these are the ones that you really need to worry about. Just like you have to be very careful in patients who have, for example, UTI. You need to be careful in using SGLT2 inhibitor,
Dr. Hussein, there is a question. I think it's a sort of a personal question. Do you have in your hospital any multidisciplinary obesity, OBD, outpatient clinics?
I can say that we have a seed for a structure, but in order to really have a state-of-the-art, let's say, comprehensive multidisciplinary weight loss management program, not just do you need physicians who are certified or nurse practitioners who are aware and capable of measuring and doing everything at a high level of standards. But you also need exercise physiologists, you need physiotherapists, you need bariatric surgeons, you need post-care nutrition services. I personally don't work in that firm, but I collaborate with other people. And I'm glad to say that Dr. Shaza is one of our collaborators, even though at one point we were under one roof, but we still share mutual patients. So if you have the means of networking, then you can still preserve, patients' care to follow through. I know other centers in the region are actually excelling in this. Dr. Ali Shihri.
Right?
Yeah, thank you very much. At the end, I just want to thank each one of you for the excellent presentation and for your time. And I just wanted to thank the organizing committee of the meeting for inviting us tonight. I know it's late, maybe for Abdurrauf, it's very late. But thank you very much. I really appreciate it. And I hope we'll see you in person soon, inshallah. Thank you very much.
Thank you very much. Good night and stay well and stay safe.
Thank you very much.
Thank you very much.